Good
Good
morning.
morning. How are you?
Great and yourself?
I'm wonderful. Let me turn this down. I think this is it. Okay. Okay. How's your week?
Busy but fast, and I'm glad it's Saturday. How
Yes, yes.
about yours?
Very productive. Very productive.
Good.
So I'm excited. I'm excited for the rest. Even though I do have to work today. I got a couple projects I need to complete and some videos to edit and all the things. So I have that today. But yeah, I'm looking forward to a little bit of R&R. I got a whole one of my line dance classes is in Kentucky, and they're having a block party, and so they've invited me to do my class in the park at the block party. So we got that piece.
Okay.
So I have those fun type of things to do as well. So I'm looking
Good.
because Monday I'm probably gonna be under the covers. That's all I got.
Right.
Preparing for a whole new week. But I love September. I love this season. I guess it's being conditioned for school. Like I feel like I need new pencils, new folders, new all the things. I feel like I need the newness too. And so I'm
Mm,
gearing up and preparing and ready. Yeah. So
okay.
even though I dropped the ball on all things Saturday morning tea this week, but other than
That's it is. Look, it's so much going on. We can. There's always something to talk about.
I said, "Oh my God, there is anything out here." But we good, we good. Okay, so welcome everybody to the Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, the government, the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner. I'm the Grow with the Pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask you, yes, you joining and watching us right now, do you know what it takes to be a certified marketable medical coder? Well, before I introduce my co host, let me share with you information on a free, yes, I said free, it is free, it's all free, email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Okay. Y'all catch me every time. Sorry. Y'all know I love the music. I love the music. All right. So, if you are in Clubhouse and interested in getting more information about the 5 steps to become a certified marketable medical coder, then please click the link at the top of the house page. House. I forget. And if you are joining via YouTube, Facebook, and LinkedIn, check the video description for the link. I promise you it's in there. So joining me today is my illustrious co-host, Mr. Jesse D, registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. Happy September. My name is Jesse. I live in Philadelphia. I've been a nurse for a very long time. Transitioned into HIM in 2014. During the pandemic, 2020, I created a company, the Coding Nurse LLC, where I help nurses and other people with clinical backgrounds transition into the wonderful world of HIM.
Yes, and how is that going?
It's coming along nicely.
Love it. Love it. See, you said happy September. All I could think of was, do you remember
Yes.
September? Yes. There's always a song in my spirit.
Hmm.
It doesn't take much to activate it either. Good morning, Vicky. She says, good morning, everyone. Yeah, I love fall too. I do too. I do too. Sometimes the weather is not nice to me, but because of the extreme changes and it impacts and affects my sickle cell, but I still love the fall. I love the fall. All right. All right. So let's get into our discussion today. But before we do that and before we jump in, let me remind you that this is a conversation between us and you. And so we want you to join in and add to the conversation. If you are on Clubhouse, all you have to do is raise your hand and we'll bring you to the stage. If you are joining us via Facebook, YouTube, and LinkedIn, you all know what to do. You use the chat. Don't be shy and know that even if your opinion differs from ours, and even between the two of us differs, it still matters here, and it's welcome and appreciated. So feel free to share your voice. We want to hear from you. If you have a question, please type Q first so that we know it is a question and we don't miss it. So for those who are joining or just joining us or watching the replay, today we are asking one question, and that question is, what's in a name? And then we're also discussing mo money, not more, mo money woes. Because trust me, folks are feeling the money woes. But before we get started, we have our church announcements. Church announcements music.
I can hear it. Okay.
Gotta have a little MLK.
I think this Sunday is the senior usher board.
Uh-oh. Made me feel say usher. Those white gloves.
Yeah. And a little doily. We're gonna give him honor.
I love it. Okay. So our church announcement for today. Well, there are two that I have. And Mr. Jesse, I don't know if you have any. And if you are joining us and you have a church announcement, put it in the comment. We will gladly discuss. So the first one, I want to announce that our Patreon is ready, and we will be putting the information out and uploading it and posting it on Sunday, tomorrow. So if you are part of our lovely community, you will get email information. If you are following us on any of the social medias out here in these streets, there will be a post. So join us on Patreon. It's going to be a lot of fun. You will have access to all kinds of things like the meeting after the meeting. And some of the goings on that happens, you get a behind the scenes look at some of the stuff that we do and just all of the things. I think it's going to be fun. So it'll be an opportunity to just network a little more and provide additional helpful information for those who need it. And yeah, so I'm excited about that. So that's the first one. The second one was a surprise to me because I was like, well, I kind of get it. And it's not often that I get it. So, at least with this group, our AMA folks, they're on a roll. And moving forward, and I can say first and foremost that I do applaud the effort. The effort, that money machine is no joke. You know what I'm saying? I just love sitting back seeing what people do, and this one I just sit back and be like, wow, wow. So recently they have put out information on how to reduce the unintended burdens for clinicians. They are allowing or asking the health system leaders to consider de-implementing processes or requirements that add little or no value to patients and their care teams. And they're starting with a checklist that offers some actions for them to consider, some de-implementation actions for them to consider. First one is with the EHR. So they're asking them to minimize alerts. They're asking that they retain only those alerts with evidence of a favorable cost benefit ratio. They want to simplify login, simplify and streamline the whole login process, leveraging options like single sign-on, RFID proximity identification, and or bio identification like the fingerprint or facial recognition. Extend time before auto logout. So, in certain workstations, it's a set time that it automatically take you out. And then, of course, you got to go back and log in with these complex login processes that they want you to simplify. So they're asking to consider customizing workstation location and security level to use patterns of the specific user so that it's not an automatic workstation auto logout. Decrease password related burdens. So consider extending the intervals for password reset requirements. Woo, child. I remember I had never seen anything like it. It was like every 15 to 30 days that you had to change your password. I'm like, this is bananas. So I do appreciate that. Help users create passwords that are both strong and easy to remember, i.e., by allowing special characters and spaces, and by allowing longer passwords that can be passphrases. And then consider use of password keeper programs. One of the things somebody taught me who was in IT, and I used it when I worked in a health system, was you get your initial password, and then you can change like the ending. So the initial part was already strong, but because of the requirements of updating or refreshing your password often throughout the year, I would just change it to the quarter. So I will put the year and the quarter. And so that way I didn't have to remember something new. It was just remember what year and quarter this is when I had to go in and change it. So that's a little tea for you if you need it. Reduce clicks and hard stops in ordering. So reduce the requirements for input of excessive clinical data prior to ordering a test, and eliminate requirements to fill fields attesting to possible pregnancy in males or women over 60 years old. Eliminate requirements for password revalidation. Identify ways to reduce unnecessary requirements for users to re-enter username and password when already signed into the EHR to send prescriptions. It has a note. Organizations may choose to keep this requirement in place for opioid prescriptions, and that may be important. This one is my favorite right here. I think I did a whole little two-step holy dance when I read this one. Reduce note blow, because we've talked about that. Reduce links embedded in visit note documentation templates that automatically pull in data from other parts of the EHR, contributing to note blow, but adding little, if any, true clinical value. Reduce inbox notification. Now, this one, I don't know. Stop sending notifications for tests ordered that do not yet have results or have test results not ordered by the physician in question. Stop sending notification for reports generated by the recipient of the notification, and eliminate multiple notifications of the same test result or consultation note, and consider auto release of normal and abnormal test results to the patient facing portal when with embedded or linked patient friendly explanations. I do like that. Simplify order entry processes. Customize technology to auto-populate necessary discrete data fields if the information already exists in EHR. For example, if medical assistant has completed a discrete field for last menstrual period, optimize your technology so no one has to re-enter that data into the order for a pap smear. I like that too. And then they have a couple of things for compliance. And I remember when this was a whole back and forth battle, and still a battle in some organizations. But they want to allow verbal orders in low risk and in crisis situations as legally permitted. I don't know. I think if you open that door, the floodgates is coming. So I don't know. I don't know. I'm on the fence about that. I need to think. About that one a little longer. Reduce signature requirements. Eliminate signature requirements for forms that do not legally require a physician's signature. Eliminate order requirements for low-risk activities that do not legally require a physician's signature. For example, ear wash, finger stick glucose, and oximetry. And consider eliminating, quote, challenge questions, end quote, to electronically sign orders when the user already logged in and is actively using the EHR. Another checkbox area is evaluate annual trainings and attestations. Review current compliance training modules and consider removal of those that aren't required by a regulatory agency or for which evidence of benefit is lacking. Now, all I know is the ones that I've been involved with, they are all tied to some sort of regulatory agency. And each department that is responsible for a part of the compliance training module has to tick and tie their the purpose of the information to that regulatory. So I don't know how that one's going to work. Because most of them are. We wouldn't put it out there if it wasn't. So I don't know about that one either. But for the most part, the EHR ones, y'all got me. Anyway, reduce attestations required daily or every time one logs in. So eliminate requirements as allowed by state or federal requirements, i.e. for privacy protection attestation, that occur on a daily or every time one logs in basis, i.e. consider whether or not an annual attestation is sufficient. That one too. Quality assurance improvement. They have something for y'all too. Eliminate the rote ascertainment of learning style preference, and then perform condition screens no more frequently than recommended. So include a grace period of at least 30 to 50% of the guideline recommended time interval when constructing a performance measure from a clinical practice guideline. For example, if clinical practice guideline recommends annual screening for depression, then set performance measurement with an interval of performing this task within 18 months. Otherwise, staff will waste limited clinical resources screening more often than is required to meet the 365-day annual interval. So those are some of the things that they have recently put forward. It's called the Steps Forward, I guess, initiative. And of course, there's a website for you all to take a look at if you want to learn more on how to reduce the unnecessary daily burdens for physicians and clinicians. Mr. Jesse, you have anything?
I mean,
let me get my tea.
I don't know. I just some of it. I would say that maybe on a good day, maybe 20% of what they wanted is valid. But we know that there are a lot of checks and balances and a lot of things you have to click just in even everyday life. Like, are you sure? So basically, when the deal goes down, it can come back to you can never say, well, I didn't know. And when you have, certain, like, even with the 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 login, like, just from a security standpoint, I just can't see them changing that
Right.
because you know because you have somebody who can come, like, you might not want to log in for 30 minutes after inactivity, but in 30 minutes, if you get up and get distracted, somebody can come in and do all kinds of things right behind you under your name. So there's a whole lot of security behind the scenes that I don't think they're considering when they're making some of these requests, because they have to protect their network.
Yeah, and that protects the user, especially
Right.
that because if you walk away for something and there could be an emergency or anything that could potentially happening, you don't really have time to figure out or log off. You run in to handle that emergency, and to your point, some shady individual can come in and be like, "Oh, da 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 da," and we got a problem because ultimately, the first thing before the investigation occurs, and of course everybody is supposed to be innocent, um 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 not considered guilty before the investigation, but the first thing we gonna say is, well, you did XYZ according to the login. This was and until again the investigation occurs and it's hopefully determined otherwise. So that protects not only um and the patient. I mean, because if somebody goes in and does something shady or whatever egregious to a patient's record, and then that information, because you all know that information will follow, and the patient may not ever know, and no one may ever know until something comes up, and then boom, what is this? Well, wait a minute, doctor, you ain't never said this, that, and the third, da 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 da. So then it's just a whole hot mess. So yeah, I agree with you. That is a definitely a protection for both the provider and the organization, and ultimately the patient, to protect them other folks from getting into their record and doing anything. And I agree. There's like some of them I like that I was like, oh, okay. Because I remember, I know the EHR and things we got to do in the EHR. And be like, oh my God. But other things, you just got to be mindful of that high standard position that you love to tout. And that comes with the territory. That comes with being the lead of the team and all of the things, which brings us to our topic for today. And what's in a name? Oh, good morning, Crafty Coder. Welcome, welcome. Thanks for joining. What's in a name? So, keeping in the same vein of our wonderful friends within the AMA, well, let's get into this. So, if you are joining us, or watching the replay, again, we're talking and asking the question about what's in a name and discussing money woes. So, in the same vein related to the AMA, they recently put out an article. Oh, I'm going to butcher this name, but the first name is Andis. Let's start there. Robazinix? I don't know. I'm butchering. I'm sorry. My bad. But you know who you are who wrote this article. Anyway, it says that this health system says calling physicians, quote, providers is not okay. Now, I don't know if you've been around for as long as I've been around in this whole healthcare world, and it's been a few decades now. um I remember when the shift happened, when they began describing like lumping everybody in a provider versus a non-provider, if you will. But our folks over there at the AMA, they're special, and they not having this. They're not. At least this one particular health system feels that this is one of the ways that we can assist physicians, and by creating a hierarchy, if you will, by calling them out specifically as the clinical provider or physician that they are. So, so again, way back in the day, government and commercial insurance people use the term provider. They've been doing it for a while. Well, the physician leaders at Delaware-based Bay Health have had enough, and they are putting a stop to using the term provider when referring to their physicians. Don't remember all this physician burnout and all of this. So it says some are unaware of it, but some physicians find it a very negative and derogatory term to address them. So, says one of the physicians, Dr. Thomas Vaughn, it is felt to have come from insurance companies and others who are trying to make medicine transactional as opposed to a relationship between patients and physicians. Dr. Vaughn is the Chief Wellness Officer and founding chair of the Physician Wellness Committee at Bay Health. He's also a member of AMA Health System program that are helping. He's probably instrumental in all of the stuff that we're seeing lately coming out of the AMA. Yeah. So he said, we discussed this in a couple of committee meetings and decided that it was an area that we could have an impact and maybe help decrease some burnout among physicians by calling them physicians instead of providers. That was my own little edit. Okay. Maybe it's a little thing, he said, of avoiding the word provider to describe physicians, but our approach with burnout is to take on a lot of little things because there is not one answer to the problems in today's medical environment. Again, many think that the term belittles the education and training required to become a physician, Dr. Vaughn said. The AMA House of Delegates agrees. It adopted policy that considers the generic term provider as, quote, inadequate to describe the extensive education and qualification of physicians licensed to practice medicine in all its branches, end quote. Similarly, the AMA also has a policy urging, quote, all physicians to insist on being identified as a physician, to sign only those professional or medical documents identifying them as a physician, and not to let the term physician be used by any other organization or person involved in healthcare. That was a dig, end quote.
Yeah.
You know, that's a whole dig right there. The policy also calls for ensuring that, quote, all references to physicians by government, payers, and other healthcare entities involving contracts, advertising, agreements, published descriptions, and other communications at all times distinguish between physician and non-physicians, and to discontinue the use of the term provider, end quote. Again, quote, calling medical doctors providers does more than inflict moral injury, says a Bay Health presentation Dr. Vaughn uses with speaking to health system staff. It reduces morale, worth, purpose, and results in already overworked doctors finding less meaning in the work they do. The word provider comes between doctors and their patients, thus chipping away the joy in practice. End quote.
The joy.
The joy. Let's see. Wait, do I need to talk about that? The editor, he has an editorial, or his presentation has been part of Mayo Clinic Proceedings editorial, which notes respect is a cornerstone of professionalism in medicine. The language we use is a critical medium through which respect is conveyed to colleagues and patients. Let's see. And other folks are on board, also on board with avoiding the use of providers are the American College of Physicians, the American Academy of Family Physicians, and the Journal of Graduate Medical Education. It says, meanwhile, physicians with the University of Wisconsin School of Medicine and Harvard Medical School explained in a journal, the JAMA Viewpoint column, that, quote, the personalized, important nature of healthcare depends on the trust and professionalism, with the exception that clinicians will place the needs of those they serve ahead of their own and those of their organizations. When used to designate those who care for patients, provider has the potential to suggest that patients are mere consumers, serviced without commitment to professionalism, the column says. At Bay Health, the word provider has been removed from medical staff bylaws, and if it is spotted as a substitute for physician in any of the health system's publication or other materials, a call is placed to gently explain the new policy. The person using the term is often well-intentioned, so Dr. Vaughn said he approaches the call with sensitivity to avoid putting the other person on the defensive. When people see you doing things for them and that you're advocating for them, whatever it is, I think it's helpful for morale and helpful for everybody, Dr. Vaughn says. It takes a lot of little things to change the culture. So what is in a name, Mr. Jesse? You got to say.
I mean, I just don't. I just can't imagine a world where something like that could be so morally insulting. Like I just, because if you want to, cause see, you know me, if you want to go down like the moral road, I mean, I think it's morally insulting to steal money from Medicare and Medicaid. It's a whole nother story. I think it's immoral to sell prescriptions. I think it's a whole lot of things that are morally insulting. So we, if you want to go there, if you want to play tit for tat, we could do that all day long. And a name will be on the very bottom of the list after we get through the billions of dollars they done stole.
That, I think it's morally wrong to experiment on marginalized groups of people. I think it's morally wrong to not provide optimal healthcare and medicine to all groups of people who come in, regardless of their ability to pay, and regardless of how they look, how they present. I think it's morally wrong to look. We can go on for days. I'll just
I'm telling you, like you because they're basically tripping over a name.
I think it's morally wrong to be trying to protect your brother and sister physician, knowing they wrong, and you're not saying anything and stepping up and saying something about what they may or may not have done. I think that's morally wrong. I think that whole big brother protection thing, yeah, call them out. When you see something, say something. Call it out. I think that's morally wrong. But go ahead. I'm sorry.
I mean, with the state of healthcare being what it is, I think this is a waste of time.
Well, to Miss Vicky's point, yeah, they're very special, all right, and special people got to keep their power.
Mm-hmm.
And the crafty coder said, man, just document the notes properly and we can worry about logistics later.
That part.
Ooh, I just, I don't think, and honestly, I really don't think that people don't recognize the education, the time, the sacrifice. I don't think people not recognize that and respect that. I just think there's a fine line between the respect that they are trying to get versus the old school, quote unquote, reverence that they used to have. And folks are not, that's a no. No. I think that's a no. So I think folks understand, and I took my mom to the doctor a couple weeks ago, and so I be on swivel, like looking for stuff. And at this particular organization, they're intentional, and I think a lot of organizations do this now. Intentional with the badges. Well, it'll say like you have the badge and you say whatever, but then there's a separate little badge that hangs out that says they are a physician or they're a nurse practitioner or what they're a medical assistant or whatever that role is. And I know when I worked in an organization, you had to walk in there without a badge if you want to. We got problems. Well, you really couldn't even get in if you ain't have a badge, but you had a problem. So I think organizations and people understand, who they're dealing with. You can look at the badge and see that. I think the dig about using the term physician was that was a little bit much because that was a straight dig to the PAs of the world, I believe. But yeah, they coming for all y'all. Y'all know that, right? But I think for me, provider, I don't know. They say provider or non-physician provider. I mean, they do differentiate between the two. I mean, you are a provider, right? Aren't you providing care? At least you're supposed to be, right? At every level.
It's just
yeah.
They're just trying to just differentiate themselves, and they're trying to slowly backdoor it into making it legal, becoming legal. And I just don't think that's the route to go when healthcare is hanging on by a thread as it is. Like that, this is not a hill on which I think they want to die. I mean,
and to your point, I think there are other fights to fight. I think there are other, ways to. I mean, look at, for example, and in other realms, we talk about like the maternal mortality rates, and what's happening with some of the cancers and other diagnoses and diseases that folks that could have been prevented, but folks are not paying attention to either the information they're getting through data or whatever. I think there are other fights that could actually be more worthwhile.
right.
I don't know. Bless their hearts. They tried it though. They tried it. They tried it. Oh, okay. And then our Mo Money segment. Look, we should make this a segment because I swear I get this every week. So I remember, it had to be 8 years ago, maybe 10, when there was a big thing about durable medical equipment providers and around oxygen. And I remember it caused a change in the process that I think at some point the patients, it required some sort of attestation from the patients because something was going on with oxygen way back then. And apparently it's still going on. So in an article from the Spokesman Review, this is from Spokane, Washington. Who wrote this? Emma Epperly. So Lincare is a company that provides oxygen equipment. Well, they have agreed to a $29 million settlement to resolve claims that were brought by whistleblowers. I need a whistle. Whistleblowers. That's next. I'm going to find one. That it was overbilling Medicare. It is the largest ever healthcare fraud settlement in the Eastern District of Washington. So Lincare Holdings is based in Florida, and they have also agreed to extensive corrective action. I'm sure they got a CIA as a result. According to a news release issued by the U.S. Attorney's Office in Spokane, they said, I am appalled by Lincare's admitted past practice of putting profits before its obligations to patient and to the Medicare program, and in particular by Lincare's admitted improper practice of wrongfully collecting co-pays from elderly beneficiaries on fixed incomes with limited means. That was from the U.S. State's Attorney for the Eastern District of Washington, Vanessa Waldroff. The settlement requires Lincare to refund wrongful payments made by Medicare beneficiaries and set up accountability measures to prevent future fraudulent billing. Of course, Lincare did not respond to a request for comment. So Lincare provides medical equipment, including oxygen tanks and concentrators in 49 states, excluding Hawaii. And in many rural communities, it is the only option. Medicare reimburses providers like Lincare for the lease payments for 3 years until Medicare has paid the full price of the equipment. So, following the 3-year period, Lincare is required to continue providing the equipment without reimbursement. That rule also applied to Medicare Advantage beneficiaries who can elect to receive their benefits through a private insurance plan. The majority of people affected by this in this case were Medicare Advantage members. Y'all know they coming for all things Medicare Advantage, so low-lying fruit right there. But anyway, Lincare admitted that it continued to bill Medicare, Medicare Advantage, and beneficiaries after it had already received 3 years of payments. Now, that could be relatively small dollar-wise, $25 a month. But obviously, if you're an elderly person on a fixed income, that can make a difference. The fraudulent billing took place across the country, so it was system-wide. The company lacked adequate controls to ensure that Medicare Advantage plans and beneficiaries weren't improperly billed, according to the settlement, and the controls in place for traditional Medicare recipients were not always effective either. Benjamin Montgomery and Brandon Haugen, employees at a Lincare center in Libby, Montana, raised concerns to officials at the Regional Billing and Collections Office in Spokane Valley and at corporate headquarters in Clearwater, Florida, when they noticed the problem. The employees were told Lincare would continue its billing practices, according to the news release. Both men were identified in a news release by their attorneys at Philip and Cohen, a San Francisco-based firm. And this practice dated back to 2011 in some cases. We raised concerns about how Lincare was charging patients for oxygen equipment. When that did not fix the problem, we decided we had to step forward. We hope this settlement will lead to Medicare beneficiaries getting their money back. The employees went on to file a whistleblower complaint in May 2021. We live in a small town and saw how the changes affected our neighbors, including our own families. We needed to do all we could to make sure the seniors were not overcharged. As part of the settlement, the former employees will share more than $5.6 million. The company will also pay more than $12 million in restitution. The majority of the rest of the settlement is effectively a punitive fine and will be paid to the U.S. Treasury Department. Oh yeah, here it is, the CIA. Lincare entered into a 5-year corporate integrity agreement that requires reform and increased oversight of the company's billing practices. The agreement makes Lincare's accountability more than just writing a check and instead requires cultural change that hopefully will prevent future fraudulent billing. This case was so meaningful to me because most of the people who receive the needed oxygen care are elderly members of the community and are on fixed income. And so not only are we going to be able to fix this moving forward with companies like Lincare, we're bringing attention to this issue more broadly. They also mentioned under Waldron's leadership, the U.S. attorney's office had prioritized healthcare fraud. And last year, it reached a $22.7 million settlement with Providence over Medicare and Medicaid fraud discovered through a whistleblower complaint against 2 Walla Walla neurosurgeons. So they are making fraud an important thing to monitor in their region. And they also feel that it's important because at times in our lives, we're all patients and we all need to trust our doctor or physician, as they like to be called. And it's so important to be able to have a community where you know that the people taking care of you are valuing your health over profits. More money, more problems. Mr. Jesse.
I've joined that entire article. I didn't hear one sentence that had a moral insult in it. You know, I'm not even going there. That what I got to say is for after the meeting.
So you're missing out, y'all. Make sure you join the Patreon. Picking blades of grass one by one is more important than provider or not provider. Exactly. Yeah. So, like I said, and then in those instances or those areas where Lincare is the sole provider of these oxygen tanks, they have made that money that they paying back is just a tap in the bucket. They have made mass money because not only were they continuing to bill the patient, but they were still continuing to bill the insurance plans. They just getting all the money. Bless their hearts.
Yeah.
Bless their hearts. So this puts folks on notice. Again, we've seen physicians being in trouble and having to make repayments and be on corporate integrity agreements. We've seen other providers be a part of that. We've seen labs. We done seen the whole gamut, I believe. Nursing, skilled nursing facilities, pharmacists. We done seen it all. Just everybody. So they're not playing out here in these streets. So make sure your stuff is right. Please.
Please. And thank you.
And thank you. Make sure your stuff is right. All right, Mr. Jesse, did you have any? Oh, there's a question. How do we get to Patreon and what is it?
Oh, I think she means Patreon.
Patreon. Oh, so Patreon is I'm like them that football team, the Patriots. Wait a minute, that's a whole other conversation. No, Patreon is a portal that allows a membership into a group or organization or what have you. And so it provides an opportunity for us to provide exclusive material to you. So we may be making a few changes with our Saturday morning tea, where if you are part of the Patreon, you get exclusivity into the makings of and the ins and outs, and we may be providing smaller snippets to others who are not part of the group. And you will also get access to the meeting behind the meeting and some of the things that we do as we prepare for our Saturday morning tea.
Good morning.
And who you talking to, sir? And we often get questions after the fact. People looking for, like, we'll bring a topic and people want to do a more deeper dive and something that may be near and dear and closer to them. We are going to allow the opportunity to do those deeper dives in a different session. So Patreon will allow us the opportunity to do that.
Okay.
Sorry, we still hear you on Clubhouse. So that will give us the opportunity to do that. And broaden our community with like-minded people. So yeah, I'll be dropping that. So if you have reached out to us, or if you've joined the or receive the free email course for being a certified marketable medical coder, you will definitely get the information because I'm sending it through our email system. If you want to email me directly to get the information regarding Patreon, wait, let me see. Where's my banner? Here's my email here. You can shoot me an email and I'll make sure that you are on the list to receive the information when we drop the Patreon on tomorrow. All right. Any other questions, concerns? Mr. Jesse, you have anything for the good of the order?
I just don't. Well, I don't know. I think we might have to make a topic about these whistleblower lawsuits, like how to file one.
That would be a Patreon. That will definitely be a Patreon because we're going to pull out pen and paper. Everybody get your stuff, and this is what you need to do. Yeah. You ain't going to have the government knocking on my door. These organizations point at me.
And the reason why I say that is because, you know, like I've gone through 2 organizations that have been caught up in stuff and told them it was going to happen before it happened. And I'm like, you know, and I said to myself, I'm not going through this again, because why should I be the one to have to change or leave a job or find another job? I'm like, when this happens to me again, I'm gonna get some information and I'm going to get paid and retire. That's what I'm going to do.
And let me share this story with you. So some years ago, there was a compliance officer of an organization that she had received information from staff. I believe it was tied to revenue cycle. I'm almost 100% certain that it was tied to revenue cycle activity. But she had received information, and she did what her due diligence was in investigating, finding, what was going on, trying to figure out the root cause, all of the things that a compliance officer that we've talked about for the last couple of weeks is supposed to do. She did her part, and she reported the information up through her leadership. They shut all of that down. Like, we ain't doing that. Nope. We're going to continue to do what we do, how we do, and all of the things. And for a while, it just didn't sit well in her spirit. And she contemplated her next steps. And so her next steps was to contact the authorities about what she found. Because and I'm paraphrasing her, it was egregious enough that it needed to stop. This was probably the first case where an actual compliance officer came out and said something about something that was going on within the organization. I cannot think of her name, but she came to Healthcare Compliance Association's Compliance Institute, their annual conference, and told her story. And immediately, folks were like, uh-oh, like you can even hear the grumblings in the room because, of course, she lost her position. But then that added to things because that's retaliation. And so there was a whole separate ad related to the retaliation that she received. But her concern was, and the grumbling in the room was, oh my God, she will never be able to work in compliance again. She'll be blackballed. Nobody would, trust her, this, that, and the third. But lo and behold, it was quite the opposite. What happened? Organizations were she actually started, I think she started a consulting company. Organizations were coming to her to help them. How do we reform our culture? How do we get leadership to understand the importance of, when we as compliance professionals come to you and tell you something that's wrong, one, you take it seriously. Two, you sometimes you may have to take it on the chin and make the necessary adjustments. And three, don't bash the people that's bringing you the information. They're bringing it to you. They're trying to help you. They're bringing it to you for a reason. And not do it in a sleazy, shady, we still trying to cover our behind route, because oftentimes that's what it is. Like, oh, we gonna coddle them for a minute just as we cover ourselves, but really we gonna just keep on doing what we doing. No, it's serious enough. There's regulatory. I'm sure. Well, clearly, because they won their settlement, and she got a huge whistleblower settlement. Like, she ain't ever got to work again ever in her life if she don't want to. But all that to say is, on the individual level, sometimes, and we talked about this recently. We talked about, or did I say that in one of my videos? I don't know. But sometimes you have to consider if what they're doing if it doesn't fit within your moral compass, if it doesn't fit with your values and ethics, if it doesn't fit in the ethics that you signed up for as a health information professional, then sometimes you may have to be like, you know what, I'm out. And that's okay. Or to Mr. Jesse's point, you may want to gather your facts and your information and begin contemplating another path. And that would be the whistleblower path. I'm just saying. I mean, but that's a personal decision. But as I do with most things, sometimes you gotta weigh it out, pros and cons. What's the what, and decide and determine from there. So yeah, interesting.
It is
interesting, but I'm glad that it's available and it's an opportunity, and folks need to know this. And I think they do. I think organizations are well aware of, because most organizations I know are well aware, because you have like the exit interview, and everybody is afforded an opportunity to then say, what's going on or what they saw or how they felt or whatever during the exit interview. And again, a good HR compliance, a good team will go through that information and look and see if there's some validity to some of this stuff, because some of it, there is some validity, and then began to look for the root cause and move from there. So you're given information, you're given data, use the data that you're given and work it. So yeah, but ultimately the feds are out here looking for fraud, looking for mismanagement, looking for all of these things, and they're leaving no stone unturned, and no one is there. If you're involved, you're involved. And they coming for you too.
Period.
Period. Period. She said she'd be giving them, wait, did it come up? Yeah, here it goes. She said she'd be giving them the business during exit interviews. And you should. That's your opportunity to say something. But as we talked last week, you also can talk to your compliance professional. It's their job to investigate this stuff. Don't start. Don't start. Don't start. But then again, if you don't feel like they're providing you with the services that they are obligated to provide, then of course you have options. Everybody, there's a choice in everything. There is a choice in it all. Right?
Okay. Right. That's right.
I swear, sir. You play at me like I play my children. Like, okay. That's my new thing for my kids. I'd be like, oh, okay. They'd be like, but Mom, why you say, okay, I tell folks all the time, I'm not wasting breath, because that may be the last breath that I need. And so why am I wasting it on you? I may need that last breath. Okay. Well, we're at the top of the hour.
Yep.
Yeah. Yes, this was good. This was good. Thank you all for joining the Saturday morning tea or checking out the replay. What's the tea spilled today? What's the tea spilled today? I feel like it was.
Definitely.
Yes. So if this information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel. And be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And as you leave, don't forget to hit the thumbs up or like button. We need the engagement. We need the traction. We need you. Also, check out the Coding Nurse channel on YouTube, where he is dropping all kinds of gems, and y'all know how he rolls. So yes, it's a fun time over there. You are welcome. Vicky says, "Good tea for today." Thank you for joining. Thank you for being with us. So again, this has been a great session, Mr. Jesse. Do you have any final closing thoughts before we wrap up for the day?
No, as always, it's a lively discussion. I just want to wish everybody a happy and safe weekend.
Yes, be safe. Oh wait, you still muted over here on StreamYard, so hopefully they can hear you. Wish them a happy. Go ahead.
Yeah. I just wanted to wish everybody a happy and safe holiday weekend.
Yay! So again, thank you all for joining, and remember, be safe, be kind, and don't wish for it. Work for it. Until next time, take care and be safe out there. Be safe out there in these streets.
All right.